So it is my pleasure to have you here for the second webinar of pathology of the Pathology Network of SELNET. Today we'll have a presentation by Raul Pereira, and Dr. Deitos will be the moderator. I will pass now the session to Dr. Paolo Deitos if he wants to make an introduction, and then we'll go to the session. Thank you so much.
Thank you so much, David. And first of all, thanks to Raul who volunteered to give the talk today. And as everybody knows, molecular genetics has increasingly become extremely important, not only, of course, in research, but also in diagnostics. And of course, Bordeaux has an amazing tradition in genomic testing. And I always remember since many, many years ago now, that fantastic discussion we had with Jean-Michel Coindre in particular, when he had this idea actually almost 2 decades ago to implement genetics. I think with Jean-Michel, we went on this parallel track, sometimes with different views on the role of genetics, but definitely in a way agreeing on the fact that this is extremely important. So we ask Raul to try to see what are the challenges, what are the promises of the new techniques, and of course, at the end of his talk, it would be nice to share among us some ideas, some different views, or whatever. And so, without any hesitation, I will ask Dr. Pereira to start his talk and tell us what is the state of the art at the moment, based on his experience. So, thank you, Raul, for accepting to share your views.
Thank you very much for the introduction and for the invitation, Dr. Deitos and the SELNET Consortium. So I will just start with the talk that is entitled as Molecular Characterization of Mesenchymal Tumor, Promises and Challenges. So I have no conflicts of interest to declare. The main objective of the lecture is to discuss the current value and the perspectives of genetics in the diagnosis and management of soft tissue tumors. So I thought that I will start in the opposite way, the presentation this time. I will just give you at the beginning the take-home message. So my take-home message is molecular biology techniques are valuable tools. They are tools, so you need to know how to use them. They're positive points, their negative points, and when to use them. So you will use it in selected cases, and they don't replace our brains. And I think that's a really important point. We have to I think this graph here describes the process of diagnosis that is really important to keep in mind. We make a diagnosis based on clinical findings and the context, and of course we are based on morphology. We have an hypothesis, and then we can confirm using sometimes ancillary techniques that can be either immunohistochemistry or molecular techniques in some cases. After we have all this information, we can reach to an accurate diagnosis, but we cannot miss any of these particular points. Okay. So I thought it will be important to give just a small overview of soft tissue neoplasms. So sarcomas, they represent around 1% of adult cancers. This percentage is a bit more, is higher in the pediatric population, but in general, they are quite rare tumors. So they are rare and difficult to diagnose because we have many, many different types. We classified sarcomas or soft tissue neoplasms based on histology. So you have tumor line of differentiation. What that means is to what normal tissue does the tumor resemble the most. So in some cases, this is quite evident, like in liposarcoma, where you see clear-cut adipocytic differentiation, like you see in this image, and that resembles a lot normal adipose tissue. In other cases, like in Ewing sarcoma, this is less clear and it's not that evident. But basically, we can classify soft tissue neoplasm based on tumor line of differentiation, and there's really a lot of subtypes, so that increases the difficulty in classification. This is the type of classification that is used currently in the WHO classification. So we can also classify tumors, soft tissue tumors, based on behavior. So we will have benign tumors that will rarely recur, and if they do so, they will do it in a fashion that is not destructive in the area. So we also have intermediate malignancy tumors that can be divided in tumors that will be locally aggressive, but they will not metastasize, and other tumors that will be give metastasis in some cases, rarely. And of course, we have overtly malignant tumors that are clear-cut sarcomas. Finally, we have another way of classifying soft tissue tumors, and this is based on genetics. So this is like the point that will be quite important in our talk. We can divide tumors that have complex versus simple genetics. So what do we mean by complex and simple? So tumors with simple genetics will have no or minimal chromosomal aberrations in structure and number, and they are generally driven, these tumors are generally driven by gene translocations or by point mutations. You have tumors with complex genetics that will have in general numerous chromosomal aberrations, and they can be recurrent, as you will see in dedifferentiated liposarcoma, for example, that we have an amplicon of MDM2, and we have non-recurrent numerous chromosomal aberrations that are no recurrent, as you will see in undifferentiated pleomorphic sarcoma, for example. Interestingly, the morphology is a surrogate marker of molecular, and in fact, tumors that have simple genetics are in general monotonous. They have low pleomorphism, and the nuclei, they are quite similar and uniform, as you can see here in an example of dermatofibrosarcoma protuberans that is driven by a fusion involving COL1A1 gene and PDGFB in the majority of cases. On the other hand, tumors with complex genetics tend to be highly pleomorphic, as you can see here, with nuclei that vary significantly in size, and also you will find typical microscopic figures. This is an example of pleomorphic sarcoma. Sorry, could you just turn off the mic, please? Thank you. So how do we apply this to real life? I thought it will be a good idea to maybe take an example of what we do in our institute in France. So I work in Institut Bergonié in Bordeaux. We're a tertiary care center, and we have a team that is specialized in sarcoma management. What do we have in biopathology department? What are the techniques that we can use or that we use on a regular basis? Well, I have listed them here. We tend to use array comparative genomic hybridization in some cases, or ACGH, basically for testing for copy number variation in genes. We use FISH regularly. The probes that we use the most are MDM2 for liposarcomas, well-differentiated and dedifferentiated, and EWSR1 mainly for Ewing sarcoma. We also have massive parallel sequencing, or NGS, either based on RNA or DNA. We have panels that are targeted, or we also do total RNA sequencing. But this is, we use it on a more limited basis. We try to reserve it to cases that are that seem unclassified based on morphology and immunohistochemistry, or really challenging tumors to see if we can catch some fusions. We also have Sanger sequencing. We use mainly Sanger sequencing for checking for point mutations of the beta-catenin gene for desmoid mainly, and we also do it for checking for MyoD1 mutations that are it's a hotspot that you find in spindle cell and sclerosing rhabdomyosarcoma, in a subset of those. RT-PCR is used. We really don't use it anymore. We have the panel, but this has been largely replaced by techniques of massive parallel sequencing, mainly targeted sequencing. using a panel, because actually you use you don't need a lot of material, and you get a really wide array of genes that you can test at the same time. So that's why we are not using any more like RT-PCR. But basically for diagnosis, this is what we can use. These are the tools that we have that we can sometimes in some selected cases use. So what is the aim of using molecular genetics in the pathology department? It's really like three main points. You try to increase diagnostic accuracy. Sometimes you can identify molecular targets that can be useful for the patient, and also to predict tumor behavior. So really, these are the 3 points that we focus on. So I thought it will be important to give you some examples of how do we apply molecular on our department. So let's start with the example of adipocytic tumors with MDM2 amplification. This is the spectrum of tumor that covers well-differentiated liposarcoma, as I mentioned. Here we see a classical example with the adipocytes, adipocytic component and hyperchromatic nuclei, some fibrous septa with atypical cells with hyperchromatic nuclei and pleomorphism. This is a clear-cut, well-differentiated liposarcoma. If this is located in the retroperitoneum, maybe just with MDM2 immunohistochemistry, we can make a diagnosis without going to molecular. The problem is that there's also the differentiated liposarcoma that is in the spectrum, where you lose actually the adipocytic differentiation. It just looks like a non-lipogenic sarcoma. So both of these tumors are characterized by the same type of chromosomal aberration. There is an amplification on the long arm of chromosome 12 in the region 1315, and this includes various genes in this region, but the definition or the main gene that is amplified in practically all of the cases is MDM2. On immunohistochemistry, as I mentioned, you can see this expression here on the well-differentiated component. And by FISH, you can see in this picture, this is FISH, the red probe is targeting the centromere of chromosome 12, as you can see here, and the green signal is targeting the MDM2 locus. And as you can see, there's numerous green spots. So this is a clear augmentation of the copy numbers of MDM2, and they are arranged in clusters. So this was a clear-cut case of an amplification of MDM2. So as I mentioned, in a typical clinical setting, retroperitoneal tumor, well-differentiated component, immunohistochemistry will be enough for giving the diagnosis. The problem is in the sarcomas that are undifferentiated like this, in dedifferentiated liposarcoma, where there's numerous differential diagnoses, and MDM2 is not as specific actually for just confirming this diagnosis, because actually MDM2 overexpression can also be seen in other type of tumors and of sarcomas. And you can see them also when there's polysomys of chromosome 12. So that's why we tend to go to FISH in tumors that are undifferentiated like that to confirm the diagnosis. Okay, so of course, that's beautiful, that's molecular, but as you can see here, there's an indication of when you will test something for MDM2. This is based on these are the recommendations that we use currently in the French Sarcoma Network, and they are based on a paper by Clay and collaborators that was published in 2015. So you will see that we'll test sometimes recurrent adipocytic tumors, tumors that are in the deep, that are deep and they are in the extremity and they are larger than 10 centimeters in adults. Adipocytic tumors with equivocal atypia on morphology, undifferentiated tumors of the retroperitoneum, pelvis, and abdomen, and core needle biopsies of adipocytic tumors. That's something that we do mainly in the French Sarcoma Network. We tend to test all of the adipocytic tumors that are made on core needle biopsies. So once again, molecular really useful to increase our diagnostic accuracy, but the indication of the testing must be based on guidelines that specify in which case you perform or not, and this is mainly based on clinical features and radiological features. Okay, So, of course, it's important to mention also that the presence of MDM2 amplification is not exclusive of well-differentiated and dedifferentiated liposarcoma. This is an anomaly that can be seen in many types of tumor, and they are not only seen in sarcomas. As you can see here, carcinomas, GYN tumors, and melanoma can rarely have this alteration. So once again, really important to have a holistic view of the case, of the patient, of the clinical findings, radiological findings, before making an interpretation of a molecular anomaly. Just to stress furthermore this point, here I show you 3 different tumors, completely different, that share the exactly same fusion involving EML4 and ALK. So we have on this panel inflammatory myofibroblastic tumor. This was a case from the lung. This is a connective tissue tumor of intermediate malignancy that can sometimes metastasize. In this image, we have a lung adenocarcinoma. This particular carcinoma, in general, involving these fusions, generally are mucinous, and you will see them primarily in patients that are non-smokers. And on the right panel, you also see a case of a non-Langerhans cell histiocytosis, completely different on morphology. Once again, clinical setting different because these tumors tend to happen in newborns and really young children, but it shares exactly the same fusion. So once again, clinical findings, morphology, molecular in some case, and then you will make a diagnosis. Another example of another problem that we see sometimes, this is a case that I received for second opinion. It was an adult male with an axillary adenopathy, and the clinical suspicion was metastasis of an unknown primary versus lymphoma. So as you can see here at low power, you have, it was definitely a lymph node. As you can see, the lymphoid tissue at the periphery, and this lesion is, this node has a metastasis of a lesion that is partially necrotic, poorly differentiated. As you can see, the cells are rather epithelioid with irregular nuclei, and in some cases you can see some really prominent nucleoli, eosinophrenic nucleoli, and the cells are somewhat discohesive in some areas. So this is a really poorly differentiated tumor. So of course, these kind of cases, there were 1,000 immunos that were performed. All of them were negative. Everything, MITF, SOX, S100, whatever you want, everything was negative. So in general, these cases are sent as undifferentiated sarcoma because they don't express absolutely anything. But once again, this is an adenopathy, you know what I mean? So tumors that give metastasis to lymph nodes, sarcomas in particular, are pretty rare, and there are just specific subtypes that do that. So the clinical findings were not fitting with the diagnosis of a sarcoma. Once again, if you look to the morphology, you see that the cells are discohesive and they are quite epithelioid with a really an abundant eosinophilic cytoplasm. And once again, this striking nucleoli. I don't know what you guys think, but for me, this morphology was really screaming think melanoma. Even if everything is negative, think melanoma, or a really nasty carcinoma that is completely undifferentiated. So what will be the next step in this setting? It's not molecular. I'm going to give you the answer. It's not molecular, it's the phone. You have to call your clinician, your colleague actually, and you have to discuss, does this patient has any previous history of any malignancy? Does he have a previous history of a carcinoma or a melanoma? Does he have lesions on the skin of the same arm? Because these were axillary adenopathies, so probably a lesion that was on the arm who have done that. So in this particular case, it was interesting because there was not any known history of melanoma or malignancy. But I said, okay, to be honest, with this setting and this morphology, I have seen this before. So I said to myself, I'm going to try and do at least a small panel for checking BRAF and NRAS mutations. And here, as you see, with real-time PCR, there was an NRAS mutation in this case affecting codon 61. And actually, this NRAS mutation is seen predominantly in melanoma. So if you go and you check online on mycancergenome.org, for example, you can check the mutation that you find. What is the distribution on this database? So as you can see, most of these mutations are seen in cutaneous melanoma and melanoma, the vast majority. It doesn't mean that there isn't other tumors that can have the same mutation, but there's a clear hotspot in melanoma. So once again, with the morphology and the clinical findings, this is quite, orients a lot to this diagnosis. So in this case, my diagnosis was undifferentiated malignant epithelial tumor, favor undifferentiated melanoma, probably metastatic location. So based on epidemiology and the morphology and the clinical findings, we make the most probable diagnosis, and in this setting, molecular can be quite useful. Here I wanted just to share this nice paper by Dr. Againi and collaborators that actually describe this feature. There's a series of dedifferentiated and undifferentiated melanomas that they did, and actually they provide with clues for the diagnosis or for recognizing. I'm not going to read all of them, but they are all listed here. This is a nice paper. Of course, this helps to catch some of those melanomas. That it's important to do this because the management of this tumor is completely different to the ones of sarcoma. So it's really important to try to catch them. I think this article gives a nice guideline, but still, probably we miss some of these tumors when they are completely undifferentiated. This was another example of another case that we had at our institute. It was an adult male with a lesion in the popliteal fossa. As you can see, it was a large heterogeneous tumor that was deeply located. It is really near vital structures like nerves and blood vessels, so it's not a good location. We got a core needle biopsy of this lesion, and you can see this was a really poorly differentiated neoplasm that was composed mainly of round cells with high nuclear to cytoplasmic ratio, but the cell tends to be relatively monotonous, so there's not a lot of pleomorphism. As I mentioned earlier, this type of morphology gives an orientation to tumors with simple genetics. This was clear malignant with some necrotic areas that I haven't that are not seen in this picture, but we had a mitotic activity that was quite high. So when I saw this case, I was more thinking of maybe a round cell tumor. So carcinoma, melanoma, sarcoma. So we did a large panel. Everything was coming negative except for just a focal expression with pankeratin that was dot-like. This is the kind of expression that is practically never seen in carcinomas. So it was not very helpful in that way. CD99s show a heterogeneous membranous staining with some dot-like paranuclear expression. This is a kind of pattern that is not useful actually, and it only helps you to exclude Ewing sarcoma. B-core immunohistochemistry came really strongly and diffusely positive. This is a marker that is not complete, it's not very specific, but it was striking the possibility that we saw in this particular case. And CD34 was focally expressed. So this was quite a difficult case, and the diagnosis that was favored was an undifferentiated round cell tumor, favored a round cell sarcoma, probably B-core, but a panel with targeted RNA sequencing was asked in search for translocations. So 10 to 14 days later, we got the results, and what targeted RNA sequencing found is a NAP2 STAT6 fusion, and this is one of the oops moments that you can have once in a while. You know, this fusion is described primarily in solitary fibrous tumor. So actually, when I saw this fusion, I was like, I missed that case. We went to do STAT6 immunohistochemistry to confirm the diagnosis, And you can see a clear expression, nuclear expression in this case, confirming the diagnosis of a high-grade solitary fibrous tumor, high risk based on the Miko et al. And actually, I talked with in this particular case, there was not a big impact on the management of the case because the tumor was inoperable. So they started with chemotherapy and it was just going, the panel that was used, the protocol that was used of chemotherapy was not changed. But anyway, I think this illustrates well also the cases that are sometimes quite challenging on core needle biopsies, difficult to interpret it, even using immunohistochemistry, and how molecular can help sometimes in some cases to catch some of some tumors that we can miss based only on morphology. So that was the main points on diagnosis and the way that we use molecular for the diagnostic part, its utility and limits. So now I wanted to maybe discuss a bit of other potential useful application of molecular profiling. I say potentially because they are not quite used in general in the routine practice. But this may change in the future. So we can discuss molecular use for the prediction of tumor aggressiveness, for example, using the SYNSARC signature. And we will discuss also sarcoma classification based on RNA or DNA methylome tumor profiling. And we will discuss briefly these two papers. So let's start with SYNSARC. This was published in 2010 in Nature Medicine by Tivon and colleagues. So what is it? It's basically a cancer grading system based on gene expression signature related to genome complexity. Okay, and what does it does? Basically, it has the same utility as the FNCLCC grading system. It will stratify tumors, but in this particular case, using this system in two groups, either low risk of metastasis or high risk of metastasis. Okay, so just briefly, this is one of the figures of one of the series that was validated with these technique. So this was a cohort of 600 sarcomas that were tested. In this graph, you see metastasis-free survival and time in years. So in blue, you have tumors that were low risk based on the SYNSARC signature versus high-risk tumors based on the SYNSARC signature. And in the same graph, you have the FNCLCC grade of the same tumors, grade 1, 2, and 3. And as you can see, the FNCLCC system is quite useful, but still, SYNSARC seems to be particularly useful in this cohort that they use, really like giving a significant difference between groups. And as you can see here, tumors that were grade 1 based on the FNCLCC system that were around 38. When you do a SYNSARC, when you apply the SYNSARC signature in this group, you see that it looks like striking how it stratifies pretty well the tumors on low risk and high risk, even if these tumors in general based on FNCLCC will be all considered as low risk. But as you can see, the low risk tumors based on FNCLCC, you still have 9 events. And actually, when you apply SYNSARC, the low risk group only have 1 case with metastasis, and the high risk group had 8. So it seems to work for grade 1. So grade 2 also seems to be useful in grade 2 sarcomas based on FNCLCC. So it tends to give more information than the FNCLCC system. And I think this is important because grade 2 sarcomas based on the FNCLCC system represent around 40% of sarcomas, and really like grade 2 is not very informative because you will have tumors that will behave like grade 3 and others that will behave like grade 1. So it's really based on FNCLCC system, it's not really useful information if you get the grade 2. Grade 3 once again is less. It seems to be less shocking. There is a significant difference, but grade 3 tumors based on the FNCLCC system generally behaving in a bad way. Still, an important point I think you mentioned is that even if you had low-risk tumors here based on sensor, so there were almost 100 cases that were stratified as low risk, almost a third had events, so it's not a perfect system, okay? So what are the advantages maybe of sensor? Probably gives additional prognostic information, reproducibility also, more than the FNCLC system because it's a signature, so the machine gives you the results. It's dichotomic, contrary to the FNCLC system, and it can be performed in very small samples and after neoadjuvant treatment. That is something that bothers, that you cannot do or apply using the FNCLC system. And disadvantages, it is expensive. It will always be more expensive than the FNCLCC system. It's not perfect. And it seems to not be useful for every sarcoma subtype. Okay, so it's not a universal system neither. So the utility in clinical practice, we don't know yet. I think that's my answer, at least. That there's a clinical trial ongoing, neosarcomics, that is actually trying to check the utility of this signature in practice. It's still ongoing. So we'll know sometime soon, I hope. And just last but not least, sarcoma classification based on RNA or DNA methylome tumor profiling. So these were both really nice papers that were published in 2018 by Watson et al. In the Journal of Pathology, and this case in Nature, this article in Nature Communication in 2021 by Coalition et al. On methylome. So basically, what we are doing is based on deep, massive parallel sequencing of tumors. We can study the transcriptome, the gene expression in this group of tumors of tumors in general, group of tumors, 21,000 genes, and actually based on all this data, you can apply statistical methods and see if the profile of the tumor resembles one another or it differs. Here, as you can see in this graph, every little sphere that you see is one tumor that was sequenced, and cases that are near, they resemble transcriptomically, and they are in the same color, as you can see, and they occupy different areas of the space. So basically, what this does is helps us like building groups, and in general, they have common points based on transcriptome and also in general fusions. And this correlates quite well with the histological diagnosis and the type of tumor, and it actually helps also to discover sometimes if you have correct clinical settings, it can help you discover new subtypes of tumors. Of course, it has limitations. It works for some cases, but there's always outliers also. It's not a perfect system neither. But if we do a good correlation with clinics and with morphology, it really can help to define new entities. So it's a useful, I think it's a useful technique, complex, not perfect, but pretty nice. The same thing can be applied by using the DNA methylation profile, as you can see, and this seems to be also quite robust. Once again, the small color sphere represent each one tumor. When they are all in groups, it means that they resemble, they have the similar methylation profile. So once again, this correlates well with tumor subtypes, both on morphology, and it can help you maybe to arrive to more accurate diagnosis in subset of cases. Again, not a perfect system. They mentioned, the authors too, that not every case is going to be correctly identified using the method, but to be honest, looks quite useful. And maybe in the future, selected cases that are difficult to classify based on morphology and on clinical findings and immunohistochemistry could be, these techniques could be applied to see if there's some resemblance to known tumors, then maybe to reclassify tumors based on these findings, maybe. So again, these are useful techniques, but to be interpreted with caution. So in conclusion, molecular techniques are valuable tools. They can provide additional diagnostic, prognostic, and therapeutic data, but you always will need multidisciplinary expertise for its correct implementation. And molecular genetics don't replace the basic diagnostic process of disease. Please keep in mind that that is the most important point, I think. So thank you very much. I would take any question.
So thank you, Raul. That was really great. I mean, and well balanced, and I would say that I would agree on 100% of the things you said. And but anyway, before making some comments, I would like to involve people. So if anybody has a question, please, now is the moment. Don't be shy. This is a great chance.
May I make a question? Raul, thank you for your talk. For me, it was very illustrative. I'm a medical oncologist, and I think you gave a wide perspective of molecular techniques in sarcoma, also taking into account the clinic, which is very, very important. Sometimes we have doubts because of the clinical behavior of the patient, something that it's not what we expect in that diagnosis. So very frequently we ask our pathologists to perform extra exams and review the pathology. So thank you, because you integrate the clinical information and the importance of the clinical information in your talk, and I totally agree. My question is regarding the grade of coincidence of FISH and NGS. For example, when we found a patient, imagine, with a synovial sarcoma or with a suspicion of a Ewing sarcoma or any translocated related sarcoma, and the FISH is negative, in your experience, which is the percentage of cases in which you find the fusion on the NGS?
Thank you very much for your question. It really depends. It really depends on the tumor subtype. Actually, it depends. In general, for example, Ewing sarcoma, you will rarely find cases that are negative in FISH. You will mainly see them in cases that are fused with the infrequent variants like EWS1 ERG, but it's really rare. So us at Bergonier, for example, if you have, once again, good typical clinical setting, morphology that is compatible, immunohistochemistry that we are really having lots and lots of new markers that work pretty well, like CD99 and MKX 2.2, so both diffusely positive. And with FISH EWS1, we diagnose most of those cases, and we don't go to NGS, at least on a routine basis. In other cases, it can be more complicated. For example, CIC sarcomas, we know that there's around 1/3 of cases that will be negative on FISH, and even by sequencing techniques, you can miss them because sometimes they have complex rearrangements. So we tend to start by immunohistochemistry FISH. If it comes negative, and to be honest, we tend to do a lot of molecular in our center because we are a reference center and we want to classify tumor in a correct way. But I always ask myself that before doing techniques and pushing it really, really far, is this going to change like really the management and the prognosis of the patient? You know what I mean? Because, for example, in Ewing sarcoma and CIC sarcoma, even if the general pathologist miss a CIC sarcoma, it's not that big of a deal. They're going to get the same treatment in general. Sadly, we don't have a specific treatment for that. But so it's not a great.
Please, people who is not talking should simply turn off the microphones.
So it really depends. It's a long answer, but it really depends on the subtype. Once again, I think that the important message is that I think to make an accurate diagnosis, having a sarcoma reference center is super important. Having people that are specialized, both oncologists, radiologists, pathologists, is the main thing. It's not molecular that is going to give you the solution of the problem. So pushing it all the time, I don't think, for the molecular, I don't think is the necessarily the best way of achieving an accurate. I think it's a false, it gives a false sense of security.
Yeah, no, I think I completely agree that it has to be used properly, because it's not a question of doing to all patients. But regarding what you said about the management, now, I mean, we are refining medical therapy. So every year we find new characteristics of certain histological subtypes that, for example, make us anticipate anti-angiogenic therapy to chemotherapy, or to propose patients certain clinical trials based on, imagine, immunotherapy. So even having the subtype, sometimes even if it's a soft tissue sarcoma, for example, the case you presented that was a solitary fibrous tumor, I don't know if you considered in the former classification as the differentiated solitary fibrous tumor, but a malignant solitary fibrous tumor. I mean, high risk, but in the former classification, it should have been a malignant solitary fibrous tumor, right?
Yeah, it was because it had more than 4 mitosis. Yeah.
Okay. So, for example, in this case, if it's not resectable, we had proposed anti-angiogenic instead of chemotherapy. So sometimes these details make us take different decisions. So even if one, for example, in the 6 Dux sarcomas, it's true that now we manage them as Ewing sarcomas with the same chemotherapy regimen, but probably in the upcoming years, these tumors are going to be managed slightly different. So these differences are important from the oncology point of view, from the systemic therapy.
Well, Nadia,
I agree. Sorry.
No, I think I don't want to, I mean, Raul doesn't need to be defended, but I mean, the case of SFT he showed that in a way they picked up with NGS is exactly what we do every day. I mean, so that was a case was terribly difficult morphologically with an immunophenotype. So, I mean, if you see a case like that, you don't start thinking about solitary fibrous tumor, any type of solitary fibrous tumor. And what I would do as well, when you get, in a way, you get to a point in which you really need to go deeper, and so NGS is fantastic. But I agree 100% that in particular in the context of the SELNET consortium, or if we start thinking globally, that the message we're getting together that, okay, you can reach a diagnosis in, playing together clinical data, clinical presentation, morphology start first, and then you do immunohistochemistry. Then you build up genetics whenever you need. Because, I mean, I'm in exactly the same situation as Raul is. So we do extensive genetics because we are a referral center, so we like to do research on this. But the message is that in many, many situations, you can reach perfect diagnosis without going there, You mentioned synovial sarcoma. Now we went back. Synovial sarcoma, now we are thanks to the work of Sigal Kadok, now we have fantastic antibodies that will pick up exactly, the specific protein, the translocated protein. So honestly, now we don't run, genetics on synovial sarcoma anymore. We simply do morphology plus 1 shot of immuno. So, pathology is something plastic that changes through the year. But I have a question now for Raul, because one of the things that, I will be honest, tend to irritate me a little bit is, is a so-called issues, the tumor molecular board. So the strong push that we have in my country, but I suppose also in Spain, also anywhere in the world, including France, to say this comes from the medical oncologists. Oh, we should do extensive genomic profiling on all the cases, because, you know, then we pick up, you know, actionable or druggable aberration and so on. And I would like to know what is your experience, and then maybe we can reason a little bit, because this is getting a problem. Because every day now I have patients coming, you know, I have a synovial sarcoma, I have a relapse, and the oncologist asked me to do foundation one or whatever. And we know that the yield of this type of approach is ridiculously low, basically. And the other issue, of course, is on track. Now, every single day we have a patient with, let's say, any type of sarcoma that is suggested to get in track fusion. All the time I have to tell them, look, I mean, we are going to do NTRK immuno, and then if you find anything, we'll go with the fusion. But the chance to find something is less than 0.5%. But the people come to me with the expectation that, you know, 60% chance to get in track fusion. So I would like to know how France is doing it at this moment, and all the other one, of course.
So yeah, thanks for the question. So it's really complicated too here in France. Me, I have a background. I did my residency in Argentina, so I know how it works in settings where molecular is not available. So that is quite a lot of places in the world. My impression is that also there's a tendency to ask massive amounts of molecular techniques for characterization that have a really low yield, as you mentioned, and it's really something problematic, I think, because this has like definitely coming from Argentina, and I think it's something global in general, but we tend to think about the cost of the things too, and it is important. Of course, if you find something, an alteration that is druggable, that could potentially change the patient, is super important. But as Dr. Deitos mentioned, this represents a really low percentage of cases. So the problem now is not finding this alteration, is rather like how do you stratify the cases? How do you screen for thinking, okay, this case deserves getting that particular research or not? And to be honest, I have no answer yet. I think there are screening methods, so we have to refine that. But I think it is problematic because we are doing really enormous amount of molecular biology that in most cases it just doesn't help a lot. And actually sometimes it can be even confusing if to pathologists if you, that's another, to be honest, negative point that I saw in part. Not everywhere, but in part in France, is that we tend to lose, pathologists tend to lose the reflect of basic medicine, you know, of keeping in mind clinical findings on morphology, and we're going to give more importance for a diagnosis to a fusion or an anomaly for the definition of an entity, of how should it be managed. And that is problematic. I think we shouldn't lose the basic of diagnosis. That's why, at least how I learned to do pathology and medicine in general, I think is an important thing. After that, for the molecular, we do a lot here. We still have the money for doing it, so I hope it's going to continue like that. But sadly, there really is more percentage of patients that are going to get some benefit of it.
Thank you. I mean, we are sharing exactly the same experience. And by the way, the comment you made about Argentina, of course, and in many other countries. I mean, when one of the issues that was raised at WHO, when, you know, we took the decision not making mandatory genetics, was exactly for this reason. I mean, 70% of the world can't afford molecular genetics. 70% of the world can't afford proper immunohistochemistry. So when we set up rules, we should consider this kind of thing. And of course, I'm not saying that we shouldn't do, because we are lucky, so we have the resources. So I think it's very important that we go deeper and deeper using all the techniques that we can, including methylomics, including all those interesting data. But then we need to consider that the main point, the main focus should be how we can make correct diagnosis. I liked very much the point you made upon melanomas. I will tell you, there is no week in my life in which we don't get, in second opinion, cases diagnosed as sarcomas actually are metastatic sarcoma and melanomas. And the paper you mentioned by Abbas Agami is really, really great because it exactly identifies one of the major issues. And many, many times when you go back to the clinical history, you will see that the patient had a melanoma. So I fully agree with you. There are, and this is also important for Nadia and the other medical oncologists who they are very right in asking for tests that can help them treating the patients. But you know, we are still in a situation in which I would say 1/3 of the cases don't get diagnosed properly. And one of the mistakes, as Raul suggested, is just to consider, okay, but now we have genetics. Genetics is going to change the field. Actually, the Cyril Fisher published a paper, which is interesting in a way, you know, extensive application of molecular genetics in non-expert hands actually raised the number of mistakes. I mean, which is a bit surprising, but that's what happens. I mean, and so I really appreciate it. Any other question from the audience? Because we have 40 people connected. And it's a great chance because Bordeaux is a really good place for sarcomas. Indeed.
I think we have one question from Andres Rodriguez in the chat. If you want to speak, Andres, go ahead.
I think that Angelo responded before this question with the comments.
No, you're right, but he raised exactly, I mean, we can go back what Andres asked. I mean, you know, this tumor molecular board is getting a very sexy and trendy things. Everybody is getting overexcited. And, but as Raul mentioned, and actually, if we look at the two last papers that our friends from French Sarcoma Group published, the one on spectral analysis, and the other one, you know, on this attempt to use genomics as a prognostic stratification, well, the conclusion is that it is good for research and not for clinical decision making. So, which doesn't mean we shouldn't do. I don't want to be mistaken because we do. But, you know, before saying, okay, you can forget pathology, you can just use extensive genomic profiling or methylomics, just is not the point. I mean, this is a discussion we had also at WHO in particular for, I'm now very much interested in a methylation profile, but you know, sometimes you get cases in which the methylomic profile is totally meaningless. So, you know, the diagnosis is obvious and the methylation profile just would take you off the road. I mean, so we need to be very careful when Nadia, I still believe that you need a good pathologist. Of course, you need a good molecular geneticist. You need we need good clinicians, of course, as you are, as Javier is, and so on, and all our friends are across the world. But we need to train people to recognize things under the microscope and then to build on all the other techniques.
Fully agree. I mean, molecular biologists do not replace a good pathologist. No. As a perfect CT scan or very complete analysis do not supply the physical examination and the anamnesis. I mean, all those, now there are many doctors who do not look at their patients, just order a CT scan. This could be the same. You have to ask to the patient about things, and clinic is very important, as the morphology is basic for, and the experience of the pathologist is basic for make a correct diagnosis. Yeah, fully agree.
Yeah. Any other questions? Because people should not be, oh, Sylvia is very, but Sylvia is always nice to me and to, well, we all agree because, you know, Sylvia, we are all some kind of old-fashioned. I mean, so, and Raul was so lucky to be trained in Argentina. So he had to be forced on morphology. And now, you know, you get this perfect combination of morphologic expertise and genetics expertise, which is, you know, the best way to approach these tumors, I think. Nadia, I forgot how much time you have. 1 hour today, isn't it? So we're getting to the closures. Or?
So it was programmed even 90 minutes if we need, but
Also,
it depends. It's up to the audience. I mean,
to the questions, yeah.
Yeah.
You should also tell us when we will have the chance to meet all together, because although these Zoom things are nice, but I'm getting so fed up with that.
Yeah.
We want a SELNET meeting in presence.
In fact, I'm going to announce in like 5 minutes that the Peru meeting is not going to happen in September.
This is a disaster. I've never been to Peru.
I'm so sorry.
So any other question? I know, looking at the names, that we have pretty high number of people very much interested in sarcomas. So who would like to? Sylvia, do you want to make a comment, Sylvia, please?
Hi, everybody. Hello. Well, I completely agree with Dr. Pereira because, as he mentioned, I also learned first morphology, then immunohistochemistry and molecular biology came several years after. And my feeling is that sometimes oncologists push us to do molecular biology, and they think that morphology is not enough. And I think most of the cases with morphology and immunohistochemistry, with a good panel of immunohistochemistry, can solve all the problems. Perhaps today with these new kinds of rhabdomyosarcomas with round cell morphology, molecular findings can be helpful, but nothing else to add. And congratulations for your talk, Dr. Pereira. It was very nice and very useful, really. Very illustrative. Gracias.
You're welcome, de nada. So just maybe for a colleague oncologist, I think they are also in a difficult situation because, as you imagine, they are dealing with the patient like daily, and it's not difficult. It's difficult also to think that even if it's 1% or 0.5% of cases, you know that if it's a patient that we will benefit, that will mean 100% for that patient. You know what I mean? So that's the problem. That's really the problem, that we need to find a way to better stratify the cases that really need to be in screen. And it is complex, I think, but hopefully we'll find a solution.
Yeah, regarding the...
Yeah, go ahead, Nadia.
No, just to answer on the comment on the molecular screening. So, for example, in the clinic, when we see a metastatic patient, if we have, for example, foundation available on the, for example, as a screen of a clinical trial, I think we don't lose anything if we just try to find something. It is true, perfectly true, that less than 8% of patients have any targetable molecular target. But I mean, sometimes we have found patients in which we have found, for example, hyperexpression of CDK4 in histologies that we didn't expect, and we have been able to enroll them in clinical trials. So, or I mean, NTRK is, I am still waiting to find a patient with an NTRK rearrangement after more than, I don't know, 150 screenings. The day I will find it, I will make a party, but it's very difficult. But sometimes, for example, FGR amplifications, now we have clinical trials, basket trials for these rearrangements, or I don't know, it's true that it's difficult to find those patients, but if we have those tools available, sometimes we don't lose anything. It's true that we have to take into account cost and everything, but if it's a screen of a clinical trial, for example, and it gives any other chance to the patients, we explain to them that, I mean, before performing molecular panels, we explain the patients that the possibility of finding something targetable is very low. So we all know which is the situation. I think Ede wants to make a comment.
Hi, everybody. Good afternoon for you.
Oh, hi, Eddie.
Here in Mexico, it's rainy. It looks like London. But let me ask you something. What do you do when you have, I'm sorry, Nadia, but some oncologists are very pushy in the way that they absolutely need to have the molecular diagnosis, the confirmation, you know? And you're explaining to them, you're training them to understand that we need, for example, all the information we can get, all the imaging studies, because that's very important for every sarcoma, for every tumor. And then sometimes in big hospitals, referral hospitals, we have immunohistochemistry. Maybe we can have some kind of molecular studies like FISH, etc. But we don't have access to massive sequencing, for example. Or what to do? We, for example, we approach the diagnosis. We do all we can do, all the best things we can do. But sometimes it looks like it's not enough. And I get it, because it's a person, it's a patient and needs a treatment. But to make them understand that that maybe we can still rely on immunohistochemistry, as Paolo said, we need to learn morphology. We need to teach other pathologists to understand morphology first, and then apply this test. Because as Dr. Pereira said, sometimes we can get information from molecular studies, but it doesn't match with what we have on the histology, for example. So it's kind of confusing. But it looks like some oncologists said, okay, the molecular testing is saying this, and you're saying this. So how to make them understand that all has to match together to make a diagnosis, not just to put it in a blender of a molecule or something every time they invent something else, but then make them understand that this is not just a test that is going to tell them what to do for everything. So tell me what to say to them, how to teach them to be more reliable on what we pathologists said. That's for you, Nadia.
Oh my God, I think we have discovered an oncology pathology war. It seems that we are all the day fighting. So, I mean, I think it depends very much on the case. There are some cases of very undifferentiated sarcoma, for example, undifferentiated sarcoma, high grade, and that's it. That's the information we have. And sometimes, for example, we find a clinical presentation that does not fit with the suspicion of an undifferentiated sarcoma. For example, a pulmonary mass with mediastinal lymph nodes, and we suspect that this is not a sarcoma. We suspect this is an undifferentiated sarcomatoid carcinoma or other. So sometimes we push because of that, because we don't really not, it doesn't mean that we don't believe in what you are seeing on the preparation, but sometimes it's true that we all have to have the complete picture, because sometimes you are seeing just the biopsy, and if you don't have all the information, it's also difficult for you to make a
we will make a mistake. I know that we will make a mistake.
So I think it depends very much on the case. I think it's, for example, it's true that we like to have the molecular confirmation. For example, in a diff liposarcoma, we like to have the amplification of MDM2. But it's true that if we say if we see a retroperitoneal mass with a well-diff component and a dead-diff component, and it's clear that radiologically it's lipo, and we have a positive immunohistochemistry, we are not doubting about the diagnosis. It's just that we like to see the amplification. I don't know, but sometimes
I get it. I know that you have difficulties because maybe sometimes you need to have the confirmation by molecular testing. But let's face it, not everybody has everything.
no, that's true, and we understand it.
You know, Heidi, you are too nice to Nadia. I mean, that's.
But for example, I will put another example. Okay,
yeah.
Imagine a soft tissue mass in the abdominal wall of a 30-year-old female, and it's clinically the suspicion is of a fibromatosis, and the beta-catenin immunohistochemistry is positive nuclear. Sometimes we ask for the mutation, not just because of not just for confirmation of the diagnosis, but because of the potential predictive role of the exact mutation. So sometimes it's also because we want to have more information, maybe predictive. Sometimes predictive of relapse or predictive of, well, not so predictive.
Nadia, you have some kind of Milan bias now, because all right, I mean, well, the baseline that we also do the mutation on desmoids, but the truth is that clinically we are not going to use that information. We are just collecting data for the future. We know that actually it is unclear whether the different mutations, I mean, it is unclear since 15 years now. We don't really know whether the different mutation will be helpful, because in a way, you won't change the strategy of watchful waiting based on the genetics. I mean, that's the point. And you know, the question of Heidi is very important. I mean, we can answer just for fun, say what I do. Well, I'm the chairman of the multidisciplinary meeting. So if a medical oncology try to force me to do something I don't want to do, I tend to be kind of aggressive, honestly. But this never happens. I mean, because seriously, this is a discussion among clinicians, pathology work clinicians, by the way, surgeons, radiotherapists, medical oncologists, on every single patient. This is what happens in a sarcoma center. So in a way, in that context, the discussion of what type of extensive genetics could be done is the only discussion which is allowed, because the decision to run a FISH or to run NGS to detect a CIC is a decision that has to be taken by the pathologist. I mean, I don't need to be advised on what molecular genetics to do in order to diagnose the diff lipo, because thank God I invented the genetics of the diff lipo. So, you know, I would be rather offended if any medical oncologists in Paolo, oh, did you do MDM2? So, and my answer would be, where did you get your degree in medicine? In Disney World? So that's the issue. So in places like your place, where I think you have Enrique, if I'm not wrong, and his team, and in places like Bordeaux, where before Raoul was there, Jean-Michel invented sarcoma practice in France, and actually contributed to the global practice of sarcomas in the world. Is kind of easy to have a well-balanced relationship between pathology and medical oncologists, in which each other try to help each other. That's the way. But you know, this is something happens with a pediatric oncologist. We run a diagnosis of Ewing sarcoma, and the 1 second, actually, before they do the biopsy. Did you do the molecular genetics? You know, sometimes I say, no, I didn't. I'm not going to do, just to make their life horrible, because, you know, what kind of a question? We all know that we have to know. We know what we have to do. Isn't it, Raul? I mean, we are not so stupid not to know that, you know, if it is a rhabdo, is a different things from Ewing's. We know that if it's embryonal, is different from alveolar. So when you handle patients in an expert sarcoma center, I think you have pathologists that know what to do. Sylvia knows what she has to do. So, you know, it is very important that the relationship between different type of professionals develops in a mutual respect, you know. Otherwise, you know, you get into some kind of challenges and troubles, which never happened to me. I'm sure it never happens in your place, and never happens in. It should never happen also in Mexico City, though, in any other city which belongs to our beautiful network. That's my opinion. So pathologists need to be strong, need to be vocal, need to say what is right to do, but they also have to defend their expertise. So it will be the pathology to decide whether you want to sequence a desmoid fibromatosis. But the question is, do we really need to sequence the desmoid fibromatosis in order to take the clinical decision? If yes, that's fine, we're going to do. But this should be discussed in the multi-professional team, I say. And now I shut up because I talk too much.
I have another issue. For example, I know that most of us work with a team of clinicians and stuff like that. I know that will be the ideal in every country, right? But sometimes in some cases, when you have, for example, you need, or you want to publish something, we as pathologists face too the fact that for example, in the magazines, they need the confirmation. Sometimes they ask you for a serial of cases. They ask you to have the mutation. If you don't have the mutation, the paper doesn't publish, for example. So that's another thing, I know. But when you're facing this kind of challenges, and you try to make a team with your rest of the network of pathologists to get more cases and stuff like that. Doing, for example, this kind of collaborations with another countries may help, because sometimes one country has something that the other one.
A problem with connection.
Well, Mexico's gone.
Doesn't. For example, another hospitals, because we know that we're part of that, you know, to help another hospital and stuff like that. What kind of network should be done? I don't know. That's something that has been on my mind, how to help another ones with the things that you have.
Well, I think the main problem of that is in general is the financing. You know what I mean? It's like that's the thing. You need to have some financing to or develop a project on a certain domain, and then you apply for getting the financing to those things in general. But for the publication, sadly, is in many journals it's like that. You need sometimes, but sadly. There are things that are important, because molecular has also helped to increase the accuracy in diagnosis in some cases. So it's interesting too. It's important to do it, but I don't think that is completely mandatory for publishing nowadays. But it certainly gives you some more chances to get published if you do if you do more techniques. But yeah, it's in general the collaborations can be done. In general, the problem is getting the financing, but the things can be done. Depends on the subject and then the amount of cases. I don't know if I answered your question.
Yes, yes, you did. Thank you very much. Yes, I know it's difficult, but well, making a team, maybe that will help everybody, right? And thank you very much. It was very interesting. I like your presentation very much.
Thank you very much, that's very kind.
It was indeed a success, Raul. Fantastic.
Thanks, that's really kind.
So Nadia, what do you want to tell us as a medical oncologist now?
Don't see us as enemies, please.
Oh no, come on. Yeah.
No, I mean, I agree that everything has to be said as a global thing. So all the information, clinic, radiological, morphology, immunohistochemistry, molecular, everything is complementary. And of course, we rely on expertise of our pathologists. I mean, if any of you tell me this is a, I don't know, a synovial sarcoma, I believe you. This is not that I don't believe your expertise, okay?
Good. No, but you don't have to,
Thank you, Nadia, thank you.
You don't have necessarily to believe anybody. I don't believe to myself sometimes, so it's okay.
Yeah.
But I mean,
communication, sorry, but communication is extremely important, and that's why it's important to have a good expertise in centers that know good oncologists, good radiologists, good pathologists, and that we can communicate. It happens in the other way too. Sometimes there are major discordances. Thanks to the clinician, we can sometimes get the correct diagnosis. That happens too. That's why it's important to have a good, healthy communication with.
Yeah, exactly. In my experience, when we explain, I mean, when we discuss with what is our doubt or our concern, we arrive to an agreement always.
But you know, seriously now, but of course there is no enemies. It's a fantastic relationship that we built on through the years. I mean, but also you have to admit, 10% of the time, I don't know whether Raul has the same experience, he's the same with me and Chris Fletcher, 10% of the time we simply don't know what it is, I mean, independently from any genetics. So, and then the discussion starts because you can have some idea of the, you know, the aggressiveness of the lesion, but really 10% of the time, in the type of material we get, we have no pale idea what we are talking about. So sometimes, of course, the wisdom of the clinician becomes extremely relevant, because in the end you have to take a decision, because of course you are now in the front line and you have the patient there and you need to do something. And as a pathologist, we are not helping so much. So, you know, we need to be very, very much objective in knowing that when dealing with sarcomas, many times the diagnosis can be horribly challenging, and wherever you go will be challenging, not because, you know, you need like a guru to sort out the problem. So we need to be very humble and say, okay, this is, we don't know. And so, and that happens every week.
Yes, Paolo, and when you're dealing with a undifferentiated tumor,
yeah.
This is the situation when I usually ask the oncologist, you tell me what the patient has, or the radiologist, especially in that cases with, for example, pulmonary tumor with mediastinal lymph nodes, which it's better with a carcinoma, like instead of sarcoma. And then the decision is made based on all the information.